So welcome, good afternoon. Welcome to this session for day 2 of the meeting. I just outlined the program for today. The first session is session number 3, which is dedicated to a very interesting topic, resistance to long-acting antivirals, which is the new frontiers of the next years, probably. We will have a couple of invited lectures. One will be given by Anne-Geneviève Marcelin, and the second one by Charles Flexner. And then we have 3 abstract-driven presentations. Following this series of talks, we have 20 minutes for discussion. And then I would remind you that at 3:35, there is an industry-sponsored symposium, and namely the VIV Healthcare Symposium. Then we have a break, and the next session would be the Best of Posters, which is moderated by Gary Rubin. And this will end at 4:45. There is the guided posters tours in parallel sections with the 2 topics. Topic 1 is epidemiology and viral spread. Topic 2 is clinical management. And this will end, and the topic 3 is resistance, and topic 4 is on HIV DNA. Okay, and then there is a poster viewing session too, and that's all. I remind you that you have to use the question and answer or Q&A function on the portal to deliver your questions, and then I will manage the questions at the end of the presentation. There is also Meet the Speakers, like yesterday, which is dedicated to the first 2 invited lectures. So that's all. I hope you enjoyed the session. And the first talk is about resistance to long-acting antivirals, and it's given by Anne-Geneviève Marcelin for Paris. Thank you.
Hello, thank you for the introduction. So I will speak about resistance to long-acting antivirals. Long-acting agents may offer the potential for less frequent dosing. And I will speak about some examples of agents with less frequent dosing, such as injectable cabotegravir and rilpivirine, a combination of integrase inhibitor plus NNRTI. I will speak also about islatravir that has a potential of subdermal implant and weekly oral dosing. Islatravir is a new class of nucleoside reverse transcriptase translocation inhibitor. And then I will speak about lenacapavir, that is a first-in-class selective HIV-1 capsid protein inhibitor with potential subcutaneous and weekly oral dosing. These long agents may offer a lot of advantages for patients. However, there are some concern around drug resistance if the patient does not come back on time. In the Atlas and Flare studies, long-acting injectable cabotegravir plus rilpivirine has been evaluated versus daily oral 3-drug regimen. In the Atlas studies, patients were previously suppressed on the stable ART regimen. And in the Flare study, patients were naive. Patients were first treated by an oral regimen during several weeks, and then switched to long-acting cabotegravir plus rilpivirine monthly versus their continued baseline ART regimen. In the pooled analysis at week 48, long-acting cabotegravir plus rilpivirine was non-inferior to continued baseline ART with a very high rate of virological success. However, there were some virological failures with the emergence of resistance mutations in these studies. 3 in the Atlas study and 3 in the Flare study. As you can see, at time of virological failure, the 6 patients developed NNRTI resistance mutations, and 4 of them had developed resistance mutation to integrase inhibitor, 1 with a 155 and 2 with a 148, that is an important mutation for dolutegravir. So there was some questions about the presence of the L74I mutation at baseline in 5 out of 6 patients. This mutation is a polymorphic integrase mutation that is highly prevalent in the subtype A1 that we can find in Russia. So there were some questions about the presence of these mutations and the capacity of this mutation to enhance the emergence of other resistance mutation to integrase inhibitors. At failure in these patients, plasma cabotegravir and rilpivirine concentrations were below population means, but still within the range for most persons maintaining virological suppression. So there were some questions about the factors associated with the virological failure and the emergence of resistance mutation. So there was a post-hoc analysis on the effect of the L74I mutation on virological suppression at week 48. And as you can see, there was no meaningful difference in efficacy observed based on the presence or absence of the L74I at baseline in the FLAIR study. So probably there were some other factors associated to the failures. So in the ATLAS and FLAIR studies, monthly long-acting cabotegravir plus rilpivirine was non-inferior versus continued oral ART regimen. However, there were 6 confirmed virological failures with long-acting cabotegravir plus rilpivirine, and the 6 patients had NNRTI resistance mutation, and 4 of them had also integrase resistance mutation at failure. So we know that rilpivirine has a low genetic barrier to resistance, and so I think it's very important to be sure that there is no potential pre-existing NNRTI mutations before the introduction of long-acting cabotegravir plus rilpivirine. And as far as we know, L74I mutation does not seem to have an impact on virological response. So considering the long pharmacokinetic tails of long-acting cabotegravir and rilpivirine, planned coverage will be required with oral ART when injections are missed or stopped in order to avoid the risk of emergence resistance mutation in case of virological failure. So now islatravir. Islatravir is a new class of nucleoside reverse translocation inhibitor. Early studies showed that a single 10 mg oral dose of islatravir produced antiviral effects for 10 days, and that parenteral dosing as infrequently as once per year may be feasible. Indeed, active triphosphate of islatravir has an intracellular half-life of up to 128 hours. And in a phase 2b study, ART induction with islatravir plus doravirine plus 3TC, followed by simplification to islatravir plus doravirine, demonstrated comparable week 48 efficacy versus doravirine plus 3TC tenofovir in treatment-naive patients. In this study, no patient meet criteria for resistance testing. So we do not have resistance data in case of virological failure within this study. However, we have some data about in vitro resistance profile of islatravir. And you can see that islatravir and tenofovir have complementary resistance profiles. Indeed, islatravir is hyperactive against K65R. And we can see also that TAMs confer a very low level of resistance to islatravir. However, 184V resistance is additive with TAMs. And here you can see that the 184V is increasing the fold change to islatravir. In addition, in some studies conducted in macaques, we can see that among macaques treated by islatravir, there is some selection of 184V, especially for macaques treated with a low dose of islatravir and for those who had a high viral load. So in conclusion, for islatravir, it is more potent against some NRTI resistant strains than some other NRTIs are against wild-type virus. Islatravir seems to have a high genetic barrier against HIV resistance with no or very low impact of K64R and TAMs. However, 184V seems to be an important mutation for islatravir. So islatravir is currently in development for potential subdermal implants and weekly oral dosing. So now lenacapavir. Lenacapavir is a first-in-class selective HIV-1 capsid protein inhibitor with oral and subcutaneous long-acting formulations in development. It has been demonstrated a picomolar potency in vitro. And its activity has been confirmed by high potency in a phase 1 clinical study with long-acting antiretroviral profile with potential dosing every 6 months. There are some data about in vitro resistance to lenacapavir, and these data have identified capsid variants with a reduced susceptibility to lenacapavir. So we conducted a study to evaluate the frequency of this capsid substitution associated with in vitro resistance to lenacapavir in antiretroviral naive and also in experienced patients in a large panel of different HIV subtypes. And as you can see here, we did not see this in vitro resistance mutation either in naive patients or in neither in ART experienced patients, patients without PI's previous use, or patients with an history of PI failure with PI resistance mutations. So lenacapavir is currently in development for oral and subcutaneous long-acting formulations. There are some already described mutations in the capsid that has been associated with a reduced susceptibility to lenacapavir. However, in some previous study, we showed that there is a lack of pre-existing resistance mutations in naive and experienced patients to lenacapavir. So in conclusion, there is a growing possibility of long-acting ART that is becoming available for people living with HIV. Of course, those ARV with long-acting formulations should have a high genetic barrier to resistance. So there is a need to find a good companion considering the very long half-life of these drugs. And also there is a need to find a good patients candidate. There is some debates about adherent patients versus non-adherent patients who should receive these kind of formulations. Because And these have some implications, for example, to determine the coverage strategies in case of treatment interruption to avoid the risk of emergence mutations with these formulations. Thank you for your attention.
So very good. Thanks, Anne-Geneviève, for this overview of the new upcoming drugs amenable to long-acting formulations. I think there will be very much to study about resistance. Now we switch to a more patient-oriented talk. The invited lecture by Charles Flexner is about patients with poor or good adherence who will benefit more from this kind of long-acting therapy. Please.
Good afternoon. I'm going to address this topic, patients with poor or good adherence who will benefit more from long-acting therapy. I think we're all familiar with the promise of long-acting therapy. And for the next 15 minutes, we're going to think about which patient populations might derive the best benefit from it. Here are my required disclosures. So who do I think will benefit more from long-acting therapy? Patients with poor or good adherence? Well, I think the answer is all of the above. And I hope by the end of my talk, you'll understand why I think that. Why not simply ask all patients to take one pill once per day? We do have excellent co-formulated antiretroviral regimens now. Isn't that enough? Well, we certainly have good data that for many of our patients, that is not enough. And one of the best examples comes from the prevention arena. I'm going to share with you data from the IPREX study that was published in the New England Journal of Medicine almost 10 years ago. That PrEP study, which involved co-formulated tenofovir and emtricitabine, looked at the potential benefit of daily one pill once per day interventions in reducing the acquisition of HIV in MSM and transgender women. And as you can see in these Kaplan-Meier plots, the one pill once per day intervention did in fact reduce the probability of developing HIV infection. But the benefit was only a 44% reduction in risk. Why was the benefit then so low? Well, there's good evidence presented in this figure that one of the main reasons for the low benefit of one pill once per day in this prevention study was the fact that the people who got infected, the cases in this figure, in fact, were not taking their pill every day because the concentrations of emtricitabine triphosphate and tenofovir diphosphate, the intracellular active metabolites of these drugs, were either undetectable or very low in the people who became infected. More recently, there's been a head-to-head study of one pill once per day PrEP with tenofovir and emtricitabine as compared to long-acting injectable antiretroviral therapy. And that, of course, was the HPTN 083 study, whose final primary results were presented by Rafi Landovitz at the virtual IAS meeting last July. This was a very large and important double-blinded, double-masked, prospective randomized trial in which MSM and transgender women at risk for HIV infection were randomized to either a 4-week run-in of a 5-week run-in, of cabotegravir every day, or cabotegravir placebo, and then compared to either tenofovir placebo with injectable cabotegravir every 2 months for approximately 3 years, or injectable cabotegravir placebo with tenofovir and FTC, the actual drug. And at the end of that study, there was an assessment of the relative protection of each of those two regimens. Perhaps surprisingly, the long-acting regimen was substantially more effective than the daily oral PrEP. In fact, there were 3 times as many infections in patients who received the daily tenofovir M-tricytidine as compared to patients who received the injectable cabotegravir. And because this was a double-blinded and double-masked study, this removed the potential bias of patients knowing which treatment they were receiving, and so therefore, for example, not taking their daily pills because they thought they were receiving a placebo. The benefit of long-acting therapy as compared to the daily oral therapy extended throughout the up to 3 years follow-up of this study. And although it looks like there was perhaps a rise in benefit at the end of the study, this is probably just a reflection of the relatively low number of patients who were eligible for contributing endpoints at that time during the study. Remember, this was a study that enrolled 4,500 patients who were randomized to either the long-acting therapy or the daily oral therapy. One reflection of the adequacy of blinding in this study was a comparison of prevalent and incident sexually transmitted infections. And what you can see in this table is that the number of patients with syphilis, gonorrhea, and chlamydia at baseline was nearly identical in the 2 groups. And during the study, the incidence of these same 3 sexually transmitted infections was also identical, suggesting that the blind was not broken and that risk behavior was not altered as a consequence of which arm the patient was randomized to. So in conclusion, both agents were highly effective for HIV prevention. The PrEP regimen containing long-acting cabotegravir, however, was superior to a daily oral regimen in this study, with a 66% relative reduction in risk as compared to those receiving daily oral therapy. It's also important to keep in mind that this patient population was nearly identical to that in the IPREX study, and so this benefit of injectable cabotegravir is especially impressive in that context. Cabotegravir long-acting was well tolerated despite injection site reactions. And peri-infection drug concentrations and a detailed resistance profile will be needed to fully understand and contextualize these results, and those outcomes are expected to be presented later. Cabotegravir then is the first long-acting injectable agent to demonstrate robust HIV prevention efficacy in men who have sex with men and transgender women at risk of HIV. There is an ongoing prevention study with a very similar design in cisgender women, HPTN 084, and the results of that study are expected to be available within the next 12 months. There's some interesting implications for this study. One is that a single drug, cabotegravir, actually performed better in the prevention setting than 2 drugs, that is the co-formulated tenofovir and M-tricytidine. it's not entirely clear why the injectable regimen was so much better than the daily oral regimen. One possibility is the better pharmacokinetic profile over time of the injectable regimen as compared to the one pill once a day. But there are also potential consequences of non-adherence to daily oral PrEP, as we saw in the IPREX study. The adherence sub-study of this particular trial is still under analysis. It's also possible that this reflected the higher barrier to resistance of the integrase-containing arm as compared to the daily oral arm. Or it could be something else that we haven't even thought about yet. Suffice it to say, this is clear demonstration of the benefits of a long-acting formulation as compared to standard one pill, once per day antiretrovirals in the prevention setting. What about in the treatment setting? What if we compare long-acting antiretroviral therapy to one pill once per day? Well, of course, that was done in the Atlas and Flare studies, the two large randomized prospective phase 3 trials of injectable cabotegravir and rilpivirine as compared to daily oral therapy. And here are the designs of those studies. I think you all are aware that those studies showed non-inferiority of the injectable regimen as compared to continued daily oral therapy. It's important to point out, however, that it would be difficult to show that injectable long-acting therapy was better than daily oral therapy in this kind of a study because the participants were selected for suppressing their HIV and maintaining suppression while taking daily oral therapy. So presumably these were all highly adherent patients and not the poorly adherent patients we'd like to know more about. So long-acting cabotegravir and long-acting rilpivirine, given every 4 weeks or every 8 weeks, were non-inferior to standard of care antiretroviral therapy in phase 3 clinical trials. There's equal benefit in treatment naive or treatment experienced participants in the Atlas and Flare studies, but both had to be suppressed on oral therapy before starting long-acting injectables. The good news is that several studies are in progress right now examining the benefits of this 2-drug injectable long-acting regimen in patients having difficulty maintaining suppression on standard one pill once per day regimens. And that includes the AIDS Clinical Trials Group 5359 study, which is a randomized prospective study in patients with difficulty maintaining suppression on daily oral PrEP. And that study is currently underway and about 50% accrued. So I think we'll know soon from clinical trials about the magnitude of benefit of long-acting injectable therapy like cabotegravir and rilpivirine in poorly adherent patients. But until then, I think we'll have to extrapolate from the results that we're seeing in the prevention setting in HPTN 083. I'd like to thank those who contributed to this presentation, particularly Marta Bofito from Chelsea and Westminster, and my colleagues at Johns Hopkins University and the University of Liverpool, and my funding sources. And I would also like to recommend to all of you, if you wish to learn more about this, the LEAP website, long-acting extended release antiretroviral prevention website, available at longactinghiv.org. Thank you.
I think this is something that's really prompting many different questions. I think there will be, I hope there will be discussion on this topic, which are really very interesting for the clinical application of this strategy. So again, I remind people to post their questions on the Q&A with the Q&A function. So now we switch to a series of 3 abstract-driven communications. The first one is given by Christy Wick, and it's about emergence and persistence of integrase mutation T97A selected by dolutegravir. Please, Christy.
Good afternoon. I'm Christy Wick, and I will present our data on integrase accessory mutation T97A. As you know, integrase strand transfer inhibitors are the most recent and potent antiretrovirals, showing good efficacy and tolerability. They are used as first-line therapy, but also as a salvage therapy, which is the case of dolutegravir. However, resistance to integrase inhibitors could present a potential barrier to effective treatment. Many primary drug resistance mutations conferring resistance to integrase inhibitors are described in detail, but the effect of accessory mutations on resistance is not so well established. An accessory mutation T97A is a polymorphism in drug-naive individuals and doesn't provide resistance alone. Recently, our group demonstrated that T97A in the background of integrase inhibitors primary mutations 140 and 148 resulted in more than 10-fold decrease in dolutegravir susceptibility in 2 patients. However, in our patients, it is not known whether T97A was present on many variants that emerged during dolutegravir treatment or a single variant emerging and dominating in the resistant population. Thus, we use single genome sequencing to investigate the population genetics of emergence of HIV variants containing T97A, so that we could answer the question, does resistance emerge as a single lineage or as a diverse population? This graph presents the history of HIV viral load and treatment of the study participant. The patient was enrolled in the clinical study in August 2014. At that time, he was 50 years old and had previously received various antiretroviral regimens, including dolutegravir. According to HIV population-based genotypes, the virus had 2 integrase drug resistance mutations at positions 140 and 148 at the time of dolutegravir-containing regimen was initiated in October 2014. At the same time, T97A was not detected in population-based or next-generation sequencing. Salvage therapy resulted in viral load decline, being undetectable weeks 13 to 20, but rebounded at week 24 when T97A was the only additional mutation that emerged. Dolutegravir was discontinued in October 2015. For our study, we collected blood plasma samples at 9 time points, 2 prior to dolutegravir therapy initiation in circles, 1 before dolutegravir failure in yellow, 3 after the failure but still on dolutegravir therapy, and after discontinuation we analyzed 3 time points indicated in triangulars. For the analysis, we used single genome sequencing for the entire integrase region, aiming more than 20 single genomes per time point. Prior to dolutegravir therapy, HIV genetic diversity was substantial, with average pairwise distance of 1.2, which diminished during the therapy, being 3 to 6-fold lower in rebound population compared to pre-dolutegravir therapy. All sequences possessed the resistance mutation at position 140 and 148, and they persisted through the study period of more than 2 years. We didn't detect T97A in samples prior to dolutegravir initiation, but it emerged at the failure at week 24, so that 97A became the dominant variant in the population. On right, you can see neighbor joining tree of all sequences with emergence of T97A in green. At week 24, 87% of sequences contained this mutation emerging from a few variants as shown on the phylogenetic tree. Interestingly, a second distinct minority population carrying mutation at 151 was also present. However, 7 weeks after the rebound, we detected only the lineage of 97A. As I mentioned before, 140 and 148 persisted in all single genomes even after dolutegravir discontinuation in October 2015, but 97A declined and only one sequence possessed this mutation at the time point collected 1 year after discontinuing dolutegravir therapy. In addition, we used population genetics analysis for panmixia to reveal population shifts. And we detected 3 distinct populations, as shown here in different colors. Pre-dolutegravir failure, in between, and 1 year after the dolutegravir discontinuation. Next, we asked, can T97A spread by recombination? For that analysis, we used only sequences that carried T97A. At the emergence of this mutation, we identified 4 clusters based on polymorphisms indicated in different colors. 2 months later, we detected sequences that could be recombinants of previous time points, indicated in orange arrows. A half year later, more possible recombinants emerged, from which a sequence containing parts of 3 different sequences from different time points could be detected. For this sequence, we performed simplot analysis that is presented here, and you can see the same pattern that was indicated before. Finally, we wanted to know the size of population that T97A emerged from. For that, we used ultrasensitive single genome sequencing, which uses primer ID with next-generation sequencing. We retrieved in total more than 2,500 sequences from pre-dolutegravir time points and used them to calculate HIV replicating population size based on allele frequencies. In a result, pre-dolutegravir maximum replicating population sizes were large, exceeding more than 10 to the 5th. Based on mutation rate of HIV, 3 to 4 T97A mutants are expected in the pre-dolutegravir population. In addition, the viral populations were highly polymorphic, but the majority of polymorphisms were in linkage equilibrium, suggesting that recombination was common. In conclusion, we can say that T97A containing population emerged rapidly from only a limited number of distinct variants that were present in a large replicating population of HIV, exceeding more than 10 to the 5th cells in this individual. Spread of T97A during dolutegravir therapy was rapid and facilitated by recombination. All this is indicating that T97A has a strong selective advantage and that rapid emergence of resistance can occur in large populations with few resistance variants. With that, I'd like to thank the study participant, my mentor Frank Maldarelli, and all my present and previous lab members from Frank's lab and other colleagues from NIH. Though I'm still connected to Frank's lab, my permanent position is now again at University of Tartu in Estonia. Thank you.
Good morning. I would like to thank the scientific committee for having given me the opportunity to present this data. Heavily treatment experienced people living with HIV with multi-drug resistance need careful assessment to plan an effective therapy. In this light, novel approach to detect and deeply evaluate viral resistance, also archived in reservoirs, deserve particular attention. Mutational load in isolate from plasma and peripheral blood mononuclear cell could impact on virological outcome and might be a useful tool to identify patients at higher risk of virological failure. The aim of this work, for this reason, was to characterize resistance in plasma and PBMC compartments through next-generation sequencing and to evaluate the impact of mutational load on virological outcome in multi-drug resistance failing patients. We included adult patients with previous evidence of 4-drug class resistance and with an available sample for plasma and PBMC at the moment of virological failure with a viremia more than 50 copies per ml. These samples and this data were retrieved thanks to the Prestigio Registry, that is a database that collects data from patients' heavily treatment experience with multi-drug resistance in Italy. Concerning the analysis, we evaluated the resistance by using the next-generation sequencing with my seq Illumina platform, and we considered the major resistance mutation listed in Stanford Drug Resistance Database. The resistance was evaluated as intrapatient frequency and as mutational load. The mutational load was calculated by multiplying the mutant frequency in plasma and proviral DNA for the HIV DNA and the RNA levels detected in the same samples, respectively. Moreover, from PBMC genotyping, we also evaluated the ApoBec activity using the Stanford drug resistance algorithm to evaluate the presence of substitution related to ApoBec. Moreover, the resistance detected by NGS was also compared with those was observed in historical GRT stored in Prestigio database. The virological outcome was also stratified for the levels of mutational load and the ApoBec activity. We included 20 patients. In this table, you can see the patient's characteristics. The patients had a long treatment history. The 45% had a previous diagnosis of AIDS, and the Nadir CD4 count was low, and zenith HIV RNA was high in this group. At baseline, at the moment of genotyping, the HIV proviral DNA had a median of 4.5 log-10 copies on 1 million of CD4 T cells. As already told, these patients had a long treatment history with 90 years of median treatment, and they failed a median of 10 previous regimen before genotyping. Moreover, at the moment of genotyping, these patients were failing complex regimens. The half of them received complex treatment with a lot of drugs and also with investigational drugs. Concerning the NGS analysis, overall we found 255 resistant variants in the population in PBMC or plasma. The majority of these variants, the 71.4%, were already present in historical GRT. NGS detected 73 additional variants as 28.6%, mainly present in PBMC, as you can see in this pie chart. Overall, in the proviral DNA, the median intrapatient frequency of resistant variant and resistance mutational load were lower than those detected in plasma RNA, as you can see in these two box plots. On the left, the median intrapatient frequency of resistant variant. On the right, the median of mutational load for the resistance variant. In red for proviral DNA, in blue for RNA, for plasma RNA. 4-drug class resistance was detected in 26% and 68% of patients in plasma and PBMC, respectively. Complex resistant patterns were detected in all individuals, and 17% of people harbored an X4 tropic virus in at least one compartment. This complexity is represented by this figure, in which each box represents the major resistance mutation detected for an RTI, an NRTI, PI, and STI. Each bubble represents a mutation per each patient. Red bubble represents DNA mutation, RNA bubble represents the plasma mutation. The size of the bubble represents the magnitude of mutational load. As you can see, this picture demonstrates the high complexity of these patients with a lot of mutation with very high mutational load both in DNA and RNA. Concerning ApoBec activity, in proviral DNA, where the substitution related to ApoBec were commonly observed. 14 individuals had at least one stop codon in their quasi-species, but the species had the frequency less than 17%, as you can see in this table, in which are indicated the drug resistance mutation associated to ApoBec, ApoBec associated mutation at active site enzymatic, ApoBec mutation associated with stop codon, and other ApoBec substitution. 14 individual modifier heart after sample collection, and 35% of them had a virological failure. The median plasma HIV RNA and proviral DNA was higher in patients who failed, but without a statistical significance compared to those achieved virological success, as you can see in these box plots. We also stratified the variant frequency in proviral DNA and in plasma RNA according to the virological outcome, and we found that patients who failed treatment had a higher median intrapatient frequency of resistant variant only in proviral DNA, and also failing patients had a lower median intrapatient frequency of stop codon and ApoBec, so ApoBec substitution compared to those achieved success. Concerning mutational load, we found that patients who failed treatment showed a higher level of resistant mutational load both in proviral DNA and in plasma RNA. No differences were detected according to virological outcome to the levels of mutational load related to ApoBec activity. In conclusion, by this work, we can assess that ApoBec activity can be detected in proviral DNA in most of patients with 4-drug class resistance. This phenomenon was observed with a low viral burden, and seems that ApoBec-related mutation had a lower frequency in patients who failed treatment. In conclusion, mutational load both in RNA and DNA might help to identify individuals more prone to experience virological failure and guide salvage therapy optimization. I would like to thank all people involved in the procedure registry for the data collection, for the sample collection, for the management of patients, and in particular the Professor Antonella Castagna, Maria Santoro, the Professor Maurizio Zazzi, and Laura Gaddi. I would like also to thank all the patients that participated, and all of you for the attention. Thank you.
Hi, I'm Kristen Andriotto from Gilead Sciences. Thank you for this opportunity to present results from our long-term bictegravir and dolutegravir resistance selections initiated with HIV-1 containing M184V in reverse transcriptase. M184V is a common NRTI resistant substitution, conferring high-level resistance to lamivudine and emtricitabine and increased sensitivity to tenofovir and AZT. Since 3TC or FTC is a component of most ARV regimens, M184V occurs in up to 67% of people after treatment failure and has been detected in 10% of virologically suppressed clinical trial participants. M184V can also be transmitted, and is detected in about 4% of acute HIV infections, but only in 1% of chronic untreated infections due to reversion to wild type in the absence of selective pressure. The INSTIs bictegravir or BIC and dolutegravir or DTG have high barriers to resistance, and previous studies have suggested that the presence of M184V prevents development of DTG resistance. For our study, we sought to assess BIC and DTG resistance pathways in HIV with pre-existing M184V by performing parallel dose escalation selections in MT2 cells using BIC and DTG, as well as raltegravir or RAL and elvitegravir or EVG as controls. First, in the RAL and EVG controls, the selections progressed at similar rates. In these experiments, drugs began at 1x the EC50, and when viral breakthrough occurred, the supernatants were harvested and used to infect fresh cells at twofold higher drug concentrations, which we refer to as increasing the passage number, abbreviated here as P. Starting with the M184V mutant, RAL selected Q148R plus other substitutions, and EVG selected T66I, both of which are the same resistance patterns that emerge in wild-type infections. The mutations associated with INSTI resistance are shown here in bold. The final viral pools were tested at Monogram Biosciences, and the high-frequency substitutions were confirmed by population sequencing. The expected resistance profiles and reduced replication capacity based on the integrase gene were also observed. Moving on to BIC and DTG, we started 2 independent selection experiments for each drugs, the second of which we split into 2 cultures halfway through, which we call 2A and 2B. Overall, BIC and DTG took longer to step up drug concentrations than RAL and EVG, consistent with BIC and DTG having higher resistance barriers, and the BIC and DTG selections were continued for over 200 days. Remembering that M184V was a full mutant in the starting virus, and there was no selective pressure for maintaining this substitution, we also wanted to see if reversion occurred during the course of the experiment. What we found was that M184V persisted as a full mutant throughout the entire selection for all drugs except RAL, which was the only selection where we saw reversion to wild type. Looking at just the first set of BIC and DTG selections, both progressed at similar rates. By deep sequencing, at passage 4, we saw no changes in the BIC selection and emergence of S153Y and M154I in the DTG selection. S153Y is a known substitution associated with low-level resistance to INSTIs, and M154I is a polymorphic substitution not associated with resistance. By passage 6, S153Y had also emerged in the BIC selection, along with V72I, another polymorphic substitution. And by passage 10, most of these changes had become the major variant in the culture. By the final passage, BIC had also acquired G140E, and DTG had G149R. In these viral pools with S153Y, we see low-level decreases in BIC and DTG susceptibility, with fold changes 1.6 to 1.8-fold over wild type, but both drugs are still considered active. We also saw low-level resistance to EVG that was above the assay cutoff and reduced replication capacity. In the second set of BIC and DTG selections, as I mentioned, we split each into 2 sister cultures after we saw the first genotypic changes. By passage 7, the BIC selection had acquired R263K, which is the signature resistance mutation selected by both BIC and DTG. By passage 6, the DTG selection had acquired an N144D substitution at low level, which I've highlighted here in purple because it's not previously been associated with INSTI resistance. We'll look further at each selection on the next slides. Looking at just the second set of BIC selections, at passage 8, both sister cultures had R263K, and one had additional substitutions M154I and R262K, which were observed at passage 9, the final passage. As I've mentioned, M154I is a polymorphic substitution, but R262K is a novel mutation not previously associated with INSTI resistance. In the second set of DTG selections, the novel N144D mutation emerged at passage 6 at low frequency and became the major variant by passage 8. By passage 10, both cultures acquired M154I. One of the cultures also developed the R263K resistant substitution and A265T, which is a polymorphic site. In the other culture, the secondary INSTI resistant substitution E157K was acquired. Now going back to the second set of selections side by side, the integrase genotypes by deep sequencing are summarized in the top right. In the viral pools from the BIC selections with R263K, we again saw minor decreases in both BIC and DTG susceptibility, below the assay cutoff for a resistance assessment, and resistance to EVG. The DTG viral pools that contained N144D also showed low fold changes in BIC and DTG susceptibility and resistance to EVG, further implicating this substitution in drug resistance. Next, we built site-directed mutants to further characterize the substitutions that emerged. In the first set of selections, which both went down the S153Y pathway, we can see that mutants with S153Y had low fold decreases in susceptibility below the assay cutoff for BIC and DTG, and the other substitutions did not seem to have an effect, except for the triple mutant of S153Y plus V72I plus G140E. G140 is a site where we see secondary or accessory INSTI resistance, but this is usually an A, C, or S substitution. In the selection, G140E was only detected in 10% of the sequences in the final passage, and the replication capacity of this triple mutant is less than 1% compared to wild type, which suggests this virus may not be viable in vivo. Also, because of this low replication capacity, we'd like to confirm this phenotype with additional experiments. We also built site-directed mutants representing the substitutions observed in the second set of BIC and DTG selections. First, looking at the R263K mutants selected by BIC, we saw small phenotypic shifts to BIC and DTG that increased to intermediate resistance when R262K was added. As for the novel N144D substitution selected by DTG, we also saw small phenotypic shifts to BIC and DTG and some resistance for EVG and RAL. When N144D was combined with other INSTI resistant substitutions, R263K or E157K, or both the M154I and A265T polymorphisms, we saw higher resistance to all INSTIs. But again, these combinations were present at low frequencies in the selection, and the replication capacities are extremely low, so we'd like to confirm using another phenotypic assay. Finally, we also sequenced the NEF gene in all of the BIC and DTG selections, because Malay et al. In 2017 described changes in NEF, notably the 3' polypurine tract, that resulted in high-level resistance to all INSTIs. We did see 2 changes in the 6G pattern of the PPT in 3 selections at low level. We built these mutants, including the original one described by Malay, and preliminary results found no resistance to INSTIs or any other antiretroviral drugs tested. But this requires further confirmation. In conclusion, HIV with M184V and RT acquired INSTI resistance substitutions under long-term selective pressure with BIC or DTG, going down the known resistance pathways of S153Y or R263K and a novel resistance pathway N144D. The viral pools and high-frequency variants retained sensitivity to BIC and DTG, as assessed by the phenotypic assay cutoffs, but complex integrase substitution patterns, only present as minority variants, demonstrated broad INSTI resistance. However, low replication capacity suggests possible non-viability in vivo, and confirmatory phenotyping is planned. M184V was maintained throughout all BIC and DTG selections, indicating that M184V does not protect against INSTI resistance development. And finally, our data support the need for continued surveillance of novel INSTI resistance mutations, both in vitro and in vivo. Thanks for listening.
So very good. Thanks to all the speakers of the abstract-driven talks. Now we have a 20-minute slot for discussion, and
Maurizio, I think you're on mute.
okay. Okay, so thanks everybody. Thanks to the speakers. And now we have a 20-minute slot for question and answers, and so I'm trying to browse through the questions and deliver that to the specific speakers. There are two questions. One is a comment, or more than a question, to Christy Uyk. So the first is a very just an information. The question comes from Kirsten White, and the question is: since you show that T97A decreased in frequency after removing dolutegravir in your patient, what happens to the mutations, the main mutations at codon 140 and 148?
Thank you. Yeah, 140 and 148, actually, they are persistent throughout the time that we investigated. So in total from more than 3 years, and they were actually present in all sequences. So all the viruses that we sequenced, they were present there. And actually this kind of long-lasting persistence of these mutations have shown before. So it wasn't actually surprising, but yeah, 97A was diminishing.
Okay, good. Then there is one comment or also a question. I think you can comment on this. This observation comes from Andreas Chrysostomou from Greece, I suppose. And the comment is it best for patient to start as soon as possible, or should you wait for a drug resistance analysis, since there is emerging drug resistance and also recombination? Can you comment on this?
Yeah, well, as we know, the studies are showing that the early start is good, but I think it has to be case by case, and also the regional resistance, transmitted resistance should be considered. And also what kind of regimens are started, and accordingly what kind of resistance is present, and also not only the regional resistance, but also how this patient who is presenting, how the virus was transmitted, if they know, and is it possible to have the resistance already gotten through the transmission or not? I think that it's a complex question. But as we all know, that the studies show that as early as start, you will suppress the replication, and also through that recombination and selection of drug resistance. But of course, if you have some kind of minority drug resistance already there, then you can select very easily if you are not putting the high effective regimen on the patient.
Yeah, I agree with you. It's always a good occasion to mention that early start is not that straightforward if you think about resistance. Okay, then we have a question for Dr. Flexner, and it's about the risks which can be associated with early PrEP discontinuation, I guess, when using long-acting agents. So since discontinuation rates can be high, and the risk of infection can be with long-acting drugs, I mean, that there is an increased risk of resistance according to you or not?
Well, thank you for that question. Let me say that the risk of developing resistance in an uninfected patient who's receiving PrEP is that they would become infected at a time when their drug concentrations were inadequate to suppress replication of the virus, but adequate to select for resistance if the patient became infected. So first of all, it turns out that is a very low risk. And there have been very few examples of that kind of resistance developing in people who have been prescribed PrEP. So to start with, the risk is low. However, with injectable regimens like cabotegravir, because the drug concentrations can persist for many months, the risk of resistance would then persist in that patient for as long as those drug concentrations are adequate to promote resistance. We don't know exactly where that cutoff is, but I can tell you that in the HPTN 083 study, every participant was given a 30-day supply of tenofovir and emtricitabine in case they were unable to appear for their monthly injection. And so there was a recognition in that study of the potential risk of not being able to receive the next dose of injectable cabotegravir. I think it's important to educate anyone who's going to be going on PrEP with a long-acting injectable drug about the risks of resistance and the importance of showing up on time for your next injection. There will, of course, be the occasional individual who will say, I'm no longer practicing risk behaviors. Why do I need PrEP? And of course, the answer to that is, as long as you're not practicing risk behaviors, you're not susceptible to infection and resistance. But what if you spontaneously change your mind? You know, things happen that people don't plan for. And so even in such a patient, I think it would be important to provide them with a supply of oral PrEP in case they do have a risk behavior and need to take PrEP right away.
Good, thank you. May I add a short question? I mean, you know that there has been reports where people just started to take PrEP and when they were just on acute infection. In that case, do you foresee more resistance risks with cabotegravir or with tenofovir FTC?
So that is an excellent question. I think much of this, Maurizio, relates to how much circulating resistance is in the population where that person has acquired their infection, particularly resistance to the nucleoside reverse transcriptase inhibitors, tenofovir and emtricitabine. If there is no resistance, then you know, I think the chance of developing resistance to either of those regimens is still low. In part, I say that because the barrier to resistance is higher for the integrase inhibitor cabotegravir than it is for the nucleoside reverse transcriptase inhibitors. It also depends on how long that acutely infected individual remains on monotherapy. So with cabotegravir, I believe most individuals could remain on monotherapy for several months, as long as the virus they were infected with has integrase sensitivity. And that's because the concentrations of cabotegravir should be sufficiently high to suppress replication of that virus. However, if the patient has received a dose of cabotegravir and does not start oral antiretroviral therapy for, let's say, more than 3 months, and I think the critical window is 3 months to 6 months, then the risk begins to go up. And most of us would say after 6 months, we would be very concerned about the development of resistance if the patient is not taking additional antiretrovirals. So this is an area where I think we still have a lot to learn and we need more research. The good news, as I said, is I think in most cases, the risk of resistance is still quite low.
Okay, good. So I forgot to mention that the first question came from David van der Veer. So hi, David, and thank you for the question. And then I moved to a couple of questions about the talk given by Daniele Armenia. The first one is coming from Kirsten White, and the question is about the possibility to determine which are the new and previously latent genomes when you dig into the DNA genotypes.
Thank you for the question. It's interesting, and at this time I cannot answer to that, but it is a good suggestion because maybe we can check about the with using phylogenetic analysis, using the previous Sanger sequencing that we had for this patient to understand if there is some possibility to check about the old or the new viral population maybe, but at this time I cannot answer to these questions.
Okay, and then there is a technical question coming from Christy Wick. The question is, did you use primary ID for your NGS protocol? And if not, what did you use a cutoff? And also, how many copies of RNA and DNA did you use as an input, if you know that?
Yeah, for these experiments, we did not use the primary ID, and we use a standard pipeline used for HIV variants to detect HIV variants, and we retained in the analysis only species with a frequency more than 1%. And regarding the copies of DNA and RNA in this category of patients, because we analyzed the failing patients with a long treatment history and high resistance, we had a very high level of both DNA and RNA. Consider that just one patient had DNA levels less than 1,000 copies on 10 million of CD40 cell positive, and all the others had more than 1,000 copies, one than more thousand of copies of both DNA and RNA.
So may I ask you, in addition to these, switching to another kind of population, what do you think about DNA genotyping, NGS or Sanger, in people who are virologically suppressed before taking a decision on a treatment switch, for example?
Yeah, I think that we have to understand better the meaning of DNA genotyping, and this study that I presented is can help also to this. Even though we analyzed failing patients, the information about about the fact that failing patients seems to have a lower ApoB activity can be used as to explore better what happens in patients that are suppressive and switch therapy. So in this light, performing a DNA sequencing in patients who need a treatment switch can be important to understand if the evaluation of ApoB activity and the presence of ApoB substitution can maybe give some information, some predictive information about the outcome.
Okay, thanks, Daniele. I do not see any other question from the audience, so I take the opportunity to ask to Kristen Andreatta. I saw from your very nice and elegant experiments that there were several cases with some selection of mutants in your in vitro system where, and then the fold change in susceptibility to dolutegravir and bictegravir was rather low. So my question is, do you think it is worth the case to analyze other parts of the genome just because there has been some I would say preliminary evidence of some other parts, some off-target effects of dolutegravir, for example, the polypurine tract or something like that? Did you do that? Do you think it's worth doing that?
Yes, I mean, because there was some evidence previously that there could be changes outside of integrase, but I mean, I think we are starting to see cases of failures with integrase resistance in patients who are treated with dolutegravir and even in bictegravir now as well. So it still is worth looking at other parts of the genome just to see and just to find an answer, because it has been suggested previously. But we know, even in these, even with these substitutions that cause low fold changes, I mean, we see them in failing patients as well. So like R263K. So even though they're a low fold change, they are still associated with virologic failure. And we did see these, we did see a couple of these low level PPT changes in the selections.
And I think it's very interesting, your triple mutant with a very high level of resistance, the one involving 140E, which is very unusual. And I was wondering whether you had a look of the Los Alamos database or any HIV sequence repository, and looking at the frequency of 143Y and 72I, which are natural polymorphisms. I mean, how often do they occur together? Because I was wondering whether the occurrence of these two polymorphisms together is something that can make it easier for dolutegravir or bictegravir to select for this 140E and have in the end a very high level resistance mutant.
I don't know. I have not looked. I don't believe G140E is polymorphic.
No, it's not, but the other two companions are.
Oh, the S153Y, V72I. Yes.
Yeah.
Yes. So in some of our other selections, we saw G140E, not the ones I presented here, but in other past selections, we see it, but we don't really see it in patients. The replication capacity is really low. So we don't know if it's just an in vitro, if it's only something we would see in vitro and maybe not something we would see in patients, but we have seen it in other selections come up for again with elvitegravir and in combination with other resistance mutations like E92Q, we've seen it come up. So
okay, I see. If Anne-Geneviève is still online, I think she had some problems, but okay, I see her. So I just take the last 2 minutes. So short question and short answer.
Yes,
I had to answer two questions actually, but now I start with the first and then we'll see. What do you think about the failures with the combination of islatravir and doravirine? They are all very low viral load level failures. So my question is, do you think it's a matter of really a genetic barrier? I mean, we don't have the resistance data because the samples were not analyzed actually. Or do you think there could be some other kind of effect, some synergistic effects with those two interesting new drugs?
No, I don't really know if there are. I think that the level of the viral load at failure was indeed were low, below 400 copies per ml, but maybe it could be interesting to try to sequence even if the viral load are very low, because we know that above 50 copies we can try to amplify the virus. So in a clinical trial there are some criteria to define virological failures.
Yeah.
But I think the virologist should try to sequence even in case of low viral load, and maybe we could see something.
Yeah, I agree totally. It's a very important information. Okay, very good. So we have to close the session. So I would like to thank all the speakers and all of the people from the audience posting their questions. I have to tell you that the Meet the Speakers, the Meet the Speakers section has been dropped because there are some problems with the connection with the on-air platform. and Charles Flexner had to go away for another meeting. So the next meeting, the next session will be in 15 minutes, and it's one of the industry-sponsored symposium, and namely the VIV Healthcare Symposium. So I would like to thank everybody again, and have a nice meeting. Bye-bye.
Bye. Bye-bye.
Thank you. Bye-bye.